Good afternoon, class. Before I begin, please forgive me of my stuttering and mispronunciations. We will be explaining assessment method for evaluation of care. We begin with indirect oxygen problems. Our patient assessment starts right when we take our first step into the room. 1. We see the patient's positioning. They're sitting upright, trying to get more air in to their body, or tripod position with pursed lip breathing, or leaning forward and just refusing to lay flat. 2. Patient verbally tells me their shortness of breath, having trouble breathing. 3. We see the increased work of breathing. The patient is paradoxical breathing, using accessory muscles to get more air into the body. If this continues for a long period of time, the body will tire out and go into respiratory arrest. 4. Nasal flaring. This is a sign of respiratory distress, especially in neonates. They're trying to pull more air in. 5. Level of consciousness. This is where we ask questions to see if the patient is responding, awake, alert, talking, following commands. 6. Sensorium. How is the patient talking? Are they anxious, restless, agitated, confused, lethargic, disorientated? 7. Color. How well are they perfusing? Any signs of cyanosis? A delay in capillary refill? 8. Auscultation. Hear any abnormal breath sounds like wheezing, crackles, rhonchi, which can help us lead to a diagnosis why the patient is in respiratory distress. 9. Heart rate. This is what circulates oxygen. How fast or how slow is it beating? 10. Respiratory rate. Breathing faster, trying to get more oxygen in and carbon dioxide out, or how shallow they've been breathing, which means the body might be starting to fail to compensate for hypoxemia. 11. Blood pressure. Low oxygen in the blood can cause the blood vessels to narrow and increase heart rate and blood pressure to deliver more oxygen to the body. 12. Ashen gray. A sign of hypoxemia that turns skin color pale, grayish, meaning the body is shunting blood to the vital organs. 13. Mottling. The patient is looking blotchy, patchy skin discoloration due to low perfusion and end-stage hypoxemia. This patient is crashing. 14. Digital clubbing. Fingers look like drumsticks, very oval-like, meaning patient has a history of chronic hypoxemia. Now, direct oxygen problems, starting with 1. SpO2, obtained with a pulse ox, shows the percent of hemoglobin carrying oxygen. Normal range of 95 to 100%. For COPD patients, we try to keep it above 88%. 2. SaO2, arterial oxygen saturation, an invasive and more accurate measurement of getting oxygen saturated percent in the blood. Normal range 95 to 100%. 3. PaO2, partial oxygen pressure, shows us how much oxygen really dissolves in our arterial blood. Normal range 80 to 100 millimeters of mercury. 4. PF ratio shows us how well our oxygen is moving from our lungs to our blood. Normal range greater than 300 millimeters of mercury. 5. PaO2, alveolar pressure. This is how much oxygen we expect in our alveoli. Normal range 100 millimeters of mercury on room air. 6. AA gradient, the difference between expected alveolar oxygen and arterial oxygen to help understand why hypoxemia is happening. Normal range 5 to 10 millimeters of mercury. 7. AA ratio is the fraction of oxygen that makes it from the alveoli to blood. Normal range 25 to 65 millimeters of mercury. 8. CaO2, arterial oxygen content, the total amount of oxygen in the blood. Normal range 16 to 22 volume per percent. 9. PVO2, venous oxygen pressure, the pressure of dissolved oxygen in the venous blood. How much oxygen is left over. Normal range 35 to 45 millimeters of mercury. 10. SVO2, venous oxygen saturation is the percent of hemoglobin still carrying oxygen after tissue use. Normal range 60 to 80%. 11. CVO2, venous oxygen content is the total amount of oxygen left in our venous blood. Normal range 12 to 15 millimeters per deciliter. 12. DO2. Oxygen delivery shows how much oxygen is being delivered to the tissues every minute. Normal range is 1 liter per minute. 13. VO2. Oxygen consumption. Shows how much oxygen our tissues use. Normal range 250 milliliters per minute. 14. OER. Oxygen extraction ratio. The percent of delivered oxygen that our tissues actually use. Normal range is 25%. Now, when oxygen is usually the first problem, we will look at SpO2. We can look at SpO2, and depending the percentage value, we can estimate the patient's PaO2. For example, a SpO2 reading of 96% can be an estimated value of 86 millimeters of mercury, more or less. This estimation of PaO2 from SpO2 correlates with the oxyhemoglobin curve. We can get a 90 to 100% SpO2 reading, and a PaO2 is usually between 60 to 100 millimeters of mercury. But when SpO2 drops lower than 90%, the patient is losing oxygen reserve very quickly. This is how we use the 90-60, 80-50, and 70-30 rule. This is why hospitals like to keep SpO2 above 90%. To improve SpO2, we give oxygen to increase SpO2 and get a better PaO2. After a while, maybe about 30 minutes, being on a low flow device, we can recommend an ABG to get the patient's baseline. After analyzing the patient's ABG, whether it be a normal or chronic baseline, we should use the desired PaO2 formula to calculate the correct FiO2. To use that, we'll try to fix the PaO2. Depending how much FiO2 you may need to overcome the correction, you might use a high flow device that will give you a more accurate FiO2 compared to a low flow device.
If low flow devices do not work, we move on to high flow devices. Some high flow devices include a high flow nasal cannula and an air entrainment mask. But most commonly used in the hospital are high flow nasal cannulas because of its ability to be heated and humidified. Once on a high flow nasal cannula, the ROX index can be used to assess the patient's need for BiPAP or intubation. This matters because it can do an early prediction of high flow nasal cannula failure and prevent delay of additional treatment. The ROX index is calculated by taking the pulse oximetry and dividing it by the FiO2 and respiratory rate. If the patient scores a 4.88 after 12 hours, success is likely on the high flow nasal cannula. If below 3.85 after 12 hours, there's a chance of failure, and anything in between is in the gray zone and must be closely monitored.
Well, what happens if I fail the high-flow nasal cannula?
Great question. This is where we move on to other interventions. But first, we must calculate the BSA.
What is a BSA?
BSA stands for body surface area. One way to calculate BSA is by looking at a nomogram. Another way is using this formula, where BSA is in meters squared, body height in centimeters, and weight in kilograms. According to Pilbeam, minute ventilation is approximately equal to 4 times the BSA in men and 3.5 times the BSA in women. Knowing the BSA will allow you to have a targeted minute ventilation based on the patient's metabolic needs for non-invasive or invasive mechanical ventilation. Take this situation for example. Jane Doe is 5'5", weighing 135 pounds, and is indicated for non-invasive. She goes on BiPAP on spontaneous time mode, and we start off with an IPAP of 10 and an EPAP of 5. The targeted tidal volume with pressure support should be about 4 to 8 milliliters per kilogram, and the minute ventilation based off her BSA. For this patient, her BSA, when calculated, is about 1.67 meters squared. Therefore, her minute ventilation will be about 6 liters per minute. With these calculations, the frequency of this patient can also be calculated. Her frequency would total about 17 breaths per minute. However, if intubation is indicated, we would skip non-invasive and move into an invasive measure while still using the BSA minute ventilation equation.
So why do we use a target minute ventilation? It's because it's tailor-made for you. It's unique because the variables we plug into the formula is based on your height and your weight. A 5-foot person weighing 130 pounds will have a different minute ventilation than a 6-foot, 250-pound guy. It's important to understand that out of these 3 breath types, in terms of volume, one is variable, one is targeted, and only one is guaranteed. We want our patient to have the ability to trigger on the vent, while also guaranteeing their minute ventilation. So ACVC is going to be your best starting mode.
Once set on the vent, make sure to get an ABG 10 to 20 minutes or 30 to 45 minutes if not severe.
Always remember to check the chart to see if there's a verified order by the physician.
And if a patient is still not ventilating, then
You can use the information that you got from the previous ABG to plug into the desired formulas. You can then make appropriate changes to help your patient better ventilate and to better oxygenate.